Hey guys, and welcome back to Nursing Made Simple. Today I'm going to be covering COPD. We just did a video on basic lung anatomy the last week, so this week I figured we'd cover one of the most common respiratory problems that we will see as nurses. It's very, very common for patients to have COPD. Per the American Lung Association, about 5% of American adults have COPD. That's greater than 16 million people. So we see it all the time in the hospitals, you'll see it all the time in your clinicals, and it's a big one to learn about. You will be tested on it, and it's going to come up in every respiratory section that you cover while you're in school. So let's kind of talk about what it is, we'll talk about the symptoms, how the patients will present, and we'll talk about treatment and what the nurses will be focusing on in their nursing education. So with COPD, basically the definition is going to be that you have decreased air movement in the lungs along with tissue destruction. It comes in two parts. I have them written up on the board here. We have two different structural changes that happen in this COPD. So in chronic obstructive pulmonary disease, the first one is going to be this chronic bronchitis. You have just this inflammation that's there all the time, and it inflames the bronchi, okay? Not so much the main stem bronchi, but deeper into the lungs, those smaller bronchi, they get chronically inflamed. That narrows your airway and creates that inflammatory response of the body, meaning that the airway is now smaller and less air can move in and out of the lungs. So it's harder for these patients to breathe. The second change that we see is called emphysema. Hopefully you can see it there in the red writing. Emphysema is those alveoli that we talked about in the basic lung anatomy video. Those little alveoli in the lungs, they actually get destroyed. The reason for these two changes is typically, most common cause is smoking. What you'll see is that patients who work in environments where they're breathing a lot of noxious gases or chemicals, patients who smoke a lot, any kind of environmental change in your air is going to put you at higher risk for the COPD because you're breathing in these noxious gases, and then it basically just damages the lungs to the point where it progresses into COPD, and there is no cure. COPD is a chronic illness, and it's in the name, Chronic Obstructive Pulmonary Disease, and we have no cure for it. We cannot reverse it. Once the damage is done, it's pretty much there. All we can really do is manage the symptoms, try to slow the progression, and for patients that are actually willing to put in the work and follow the meds and practice healthy respiratory exercises and everything, they can actually slow the progression rather well and have decent quality of life. For your patients who continue to smoke, who don't do activities, who just sit around and let this progress and don't change anything in their lifestyle, they will progress eventually to respiratory failure. Their exacerbations will get worse and worse, and they will have less and less activity tolerance until just getting up from the couch to the bathroom is going to be too much for them to handle, and they won't be able to breathe. So it is important on the nursing side that we're educating these patients on everything we can do, and we will talk about that more towards the end of the video. So what are these patients going to look like? I have a list of symptoms here on my board. It is not exhaustive. Obviously, there are many things that we will see in many different people, and some people will present differently than others, but there are some pretty general symptoms that you will see in COPD no matter what. First on the list, cough, dyspnea, okay? These patients will chronically be coughing all the time. Because of this chronic bronchitis, they're inflamed. Their airways are irritated. It's going to trigger coughing all the time, and they're going to have a lot of mucus as well, so it will be productive coughing. That goes along with the emphysema, and then just part of that inflammatory response is going to bring more fluids into the lungs, and more white blood cells, and just a bunch of gunk gets produced. And so they're going to have all this sputum, they're going to be coughing constantly. Along with the bronchitis, because the airway's narrowed, similar to asthma, we're going to see this dyspnea. They're going to have difficulty breathing, especially when they're doing their activities of daily living. So that difficulty breathing is going to be worse when they're actually moving, when they're exerting themselves, anything that requires them to breathe harder. It's already hard to breathe, so when they're doing an activity that's requiring more oxygen, more movement, it's going to get even worse. So these patients may do just fine when they're sitting in bed, but as soon as you get them up to the bathroom in the hospital, as the nurse, no idea what their oxygen is going to do and how they're going to tolerate it until we actually do it. So we got to be careful with those guys. We're going to see some wheezing. Again, reduced airway. The smaller the airway gets, the more wheezing we're going to hear when we auscultate the lungs. It might actually be audible. We're going to see potentially these clubbing nails. I don't know if you've ever seen a picture of those, but you'll see the fingernail, instead of being nice and flat on top or like a normal fingernail shape, they get very tall, and it's called clubbing, but they're very rounded. It's kind of odd, but it has to do with hypoxia and high CO2 levels. It's just a physiological change that we see in those patients. That's more of a later sign, but once you've been living with COPD for several years, you're going to start seeing these later signs. Frequent infections, particularly respiratory infections. They're going to be super prone to pneumonia, super prone to all of the winter colds and bacterial and viral infections that we see. And those are going to trigger the COPD exacerbations that are then going to bring them into the hospital. So for these patients, practicing good respiratory hygiene and keeping clean and making sure they're getting their vaccines is going to be important for keeping them out of the hospital, because any infection they get in the lungs is just going to stack on top of the chronic bronchitis and the emphysema and make it even worse. Barrel chest. This is like the classic presentation of a COPD patient. You're going to notice the chest is just huge. They're like hyperinflated. Their lungs have too much oxygen in them, too much CO2 particularly, and it's just like they can't expire all of that extra air. So they're gonna have this big broad chest that just looks like it's over full, and that's how they're gonna live. That's just what we're gonna see with these patients. We can't really do a whole lot about it, but it is like the classic symptom of COPD. And then unintended weight loss. This is kind of more an end-stage COPD sign. The work of breathing is so high in these patients. They have to exhaust so much energy just to breathe and do their normal activities that they're going to start burning calories more. Even eating, for some of these worse COPD patients, just sitting down to eat a meal and chewing their food and swallowing it actually will exhaust them, and partway through the meal they will just start getting so tired, and they'll eat less because of it. So they start becoming then malnourished with not enough calories intake, and they get this unintended weight loss. That is more of an end-stage sign of COPD. So once we start hitting this, it starts getting really difficult to do those activities of daily living, and they're going to end up needing some respiratory support and possibly ended up in an extended care facility. So a couple other things that happen in COPD. With these two problems, the emphysema and the bronchitis, we're trying to bring air into the lungs. It's hard to bring air into the lungs, and when we do, the emphysema with those destroyed alveoli, there's less places for gas exchange to actually occur. So not only is it harder to bring the air in, but once the air's there, it's got less places to go, and our gas exchange in the lungs is worse. So what happens, normally on inspiration, we bring in oxygen, and then it switches with the CO2 down in those alveoli at the capillary beds, and then our lungs are now full of CO2, we breathe it out, and we expire the CO2. In COPD, that can't really happen very well. It's too hard to bring the air in, the gas exchange is inefficient, we end up with a whole lot of extra CO2 just trapped in the lungs. So like I said earlier, we get that hyperinflated lung. It's not able to stretch as well. When we breathe in and breathe out, the recoil of the lungs to actually refill with air and get back to their normal position is not very effective. And so we're going to end up having high CO2 levels in the body, which causes a number of physiological changes. This high CO2 level, again, because of the emphysema and the poor oxygen exchange, is going to end up actually causing some vasoconstriction in the lungs. So CO2, anytime that there's a high CO2 level, your blood vessels, they shrink, they constrict. So that's vasoconstriction, and that happens in the lungs along with all of this high CO2 level that's there locally. And that's actually going to increase your blood pressure in the lungs. So it's going to be pulmonary hypertension, okay, which just makes everything even worse. But it is a symptom that you'll see because of all these physiological changes along with COPD. So what do we do for these patients? Our treatment, for the most part, is going to be slow the progression, keep them from getting infections, and then just practice good respiratory hygiene. First thing that's probably going to end up happening with these patients, oxygen support. Along with that impaired gas exchange, not only are your CO2 levels climbing to make things worse, but your oxygen levels are dropping, because you can't have a lung full of oxygen if it's already full of CO2. So these patients will most likely, almost always, need some sort of oxygen therapy. Now that could mean they only need 1 or 2 liters on a nasal cannula through their nose. It could mean that they need to be on a BiPAP every night, or anytime they fall asleep. And if they go into respiratory failure, it could mean that they're ventilated on a mechanical ventilator. which is, worst case scenario for people. So the oxygen support will vary. There are a couple things that go along with that. They're not going to oxygenate as well as a normal person ever. So if you're trying in the hospital on your clinicals to get your patient's oxygen to 98% on their little SpO2 monitor on the finger, and they've got COPD, it's probably just not going to happen, and honestly, we don't really want it to happen. The thing with these patients is that they are now, once they've lived with this COPD for a while, that's their new body's normal. Okay, so they may not be oxygenating at 98%. They may have like 90% oxygen or even 88% oxygen, and that's just going to be their new normal where they live. That word that you learned about in school, homeostasis, where the body's in its normal functioning state. Their new normal is not as oxygen saturated as me or you. So trying to get a COPD patient to 100% oxygen is not going to happen, and it's really not good for them either because they already have hyperinflated lungs with CO2. Throw a whole bunch of extra oxygen in there, it's just abnormal for them. So if we can keep their oxygen anywhere above like 88 to 90% or above, you're usually happy in the hospital. It does not mean that we're cranking up the oxygen to get them all the way up to a normal person's SpO2 levels. So oxygen, if it progresses to a exacerbation, they may need more aggressive oxygen therapy. That could mean that we throw them on a CPAP or a BiPAP is more effective at night because it produces that positive pressure while they're inhaling to push air in, and then as they're exhaling, that pressure drops a little bit and they're able to exhale easier. So those BiPAPs work very well for these COPD patients. As it progresses, they're going to end up on one, hopefully. Every time they fall asleep, they should have a BiPAP on. Because not only are they having trouble breathing, but once you fall asleep, your breathing slows down and gets even more relaxed. So they're going to even have worse oxygenation while they're sleeping. So those BiPAPs work wonders for those patients in helping to drop the CO2 levels, help them get some of it out, and produce good oxygenation. We're going to encourage their flu vaccines every year. Again, we want to reduce the rate of infection with these patients. And then lastly, medications and nursing support. Our medications are pretty much always going to stay the same. We're going to give them bronchodilators. Goes along with the bronchodilation or bronchitis. Anytime that we have a reduced airway diameter from asthma attacks, COPD, airway spasms, those bronchodilators bring them open. Okay, and that's going to be your respiratory therapy that does that. We're going to give them corticosteroids. It's going to help with the inflammatory response that comes from the chronic bronchitis. Those are usually oral pills. But if they're in the hospital having an exacerbation, we'll start switching over to IV, get some stronger doses, and then really bring down that inflammation. Glucocorticoids, kind of the same deal there. We're going to try to bring down the inflammation levels and just help get things back to their normal. And then antibiotics, whatever infections they may have acutely working in their system, we want to treat those, get them knocked out so that the infection can stop adding on to the other symptoms. And then lastly, let's talk about the nursing support. So what are we doing as nurses? We need to encourage these patients to be coughing, deep breathing, and using their incentive spirometers. Doing purposeful, hard coughing on a regular basis to help clear secretions is actually a really good exercise for those lungs. And especially if we pair it with that incentive spirometry use that we learn about in nursing school all the time, those little tiny devices that we have patients breathe into and pull air out. A lot of people don't like doing those, but they really do work wonders for opening up those alveoli and helping to mobilize secretions. All the extra fluids from the inflammation, the sources of infection, the extra sputum production, we want to clear those out of the lungs because they're taking up valuable space for that oxygen and CO2 exchange. So by using that incentive spirometry, encouraging your patient to do that, you can have them coughing more and producing more actual secretions out of those coughs to help clear the lungs. And that will really help just clear their airways. Great for the patient. But doing it purposefully for a set amount of time really helps. And then we're going to want to encourage education on these. Why do we want to take the vaccines? Why do we want to actually make sure that we're immunized? A big part of the nurse's role is education, and a lot of these patients don't know all the things they can be doing to actually help them. So things outside of the hospital that we can actually educate them on, taking your meds, doing activities, not just sitting around and letting yourself get weaker and weaker, practicing your coughing, your incentive spirometry use at home, taking your vaccines, staying clean so that you're not getting these respiratory infections, good hand washing, good coughing, All of these different kinds of educations will be very beneficial for these patients. So, thank you for watching. I think we've covered a pretty basic understanding of COPD. Hopefully you can understand what it is, why we care about it, and what these patients will look like and what we can do for them. So if you have any questions or comments, hit them below in the comment section. I'll try to answer best as I can. And if you liked the video, like and subscribe. I greatly appreciate it. And thank you for watching.